would like to thank the organizers, particularly Professor Ravi and Nasimlu sir, for giving me this opportunity to be with you here today. In the ensuing 20 minutes allotted to me, I would like to take you through the perspective of what is new in the drugs that are used to treat TB. I hope my screen is visible to all and I'm heard loud and clear.
Yes, sir.
Right.
Yes, sir.
Yes, sir. I have not received any funding for this talk and I have no conflict of interest to declare. It's known since time immemorial that TB has been enemy number one for the humankind. And if you look at the global TB report that has just come out, I think 3 days ago, India still has about 28% of the world TB burden, and India is one of the regions containing the highest multi-drug resistant and HIV TB co-infection in the world. Sheer numbers are staggering. Therefore, we are worried about the drugs that we use to treat TB. The cupboard is not overflowing. In fact, it's about empty. I'm sure at least Narsimlu sir and people of his generation and the TB fanatics today would have read Corwin Hinshaw's textbook. Hinshaw himself writes that no one, including himself, had believed that control of TB would be attained by medical means, that is, by treatment within the 20th century. However, we have gone from the era of hope to hype to depression. In the mid-40s, we started having the anti-TB drugs. By around 1980, we were jumping up and down with joy and ecstasy, thinking that TB is no more a public health problem. In fact, when I wanted to do my MD thesis in TB, my boss told me, "Are you out of your mind? TB is on the way out. What do you want to do?" So we are today at a point where India has the dubious distinction, sitting here as a high burden country for TB, for HIV TB and MDR TB. So this is a clarion call for us to realize what we have and what we need to do. So if you look at the progress of the anti-TB drug discovery from around the mid-40s, paraminosalicylate acid, streptomycin, later on isoniazid, pyrazinamide, goes back in a higher dosage, comes back with a lesser dosage, ethambutol, and the rifamycin. And then we had a silent period close to 50 years. Nothing much happened. There were no new drugs for TB at all. The situation changed only recently by the use of what is called as multi-arm, multi-stage clinical trials. All of you know that you have phase 1, phase 2, phase 3, and phase 4 clinical trials. And if you see the number of drugs that enter the phase 1 clinical trial, of these, only 14% would actually be available for you to purchase in the market and use for your patients. So the attrition rate is close to 85%. In this scenario, planning and conducting clinical trials for TB has been tricky. So thinking out of the box, rather than doing a series of separate phase 2, 3 studies, the multi-arm, multi-stage trial strategy aims to answer multiple questions simultaneously under the same regulatory framework. Different multiple treatment options can be compared against a single control arm. And the other technique which was used was re-engineering of old TB drugs. These are examples of re-engineering of old TB drugs. The well-known example is the rifapentin and rifabutin, or the modified versions of rifampicin, as is the SQ109, which is a modified version of ethambutol. The third method, which was out of the box thinking, included the drug repurposing, where the existing or old drugs are investigated for treating other diseases. These are all the drugs that have been used as a repurposed drugs. With these three technologies, the anti-TB drug discovery progressed from here to the situation where we had bedaquiline in 2012. That's not very far away, 10 years ago. Delamanid 2014 and pretomanid in 2019. So if you look at the current cupboard of the first line anti-TB drugs, this is well known to everybody. There has been a relook at the designation of the groups for the drugs used for drug-resistant TB. The group A drugs include the quinolones like levofloxacin, moxifloxacin, then bedaquiline and linezolid. Group B would include clofazimine, cycloserine, terizidone. Group C contains all these drugs listed here, including the delamanid and the newer kid on the block, the pretomanid. Now, I'm not going to give you a huge table list or a carry home message for how to treat DRTB, whether it is MDR-TB, XDR-TB, or monopoly DRTB. You can have all these details, nitty-gritty details in the TBC India website. But I would like to focus upon, in the 20 minutes given to me, because I have Indian standard time, not the Indian stretchable time, I will focus upon the few key aspects related to the newer drugs. As on date, drugs belonging to these chemical classes are undergoing clinical trials world over, many of them in phase 1, several of them in phase 2, 3. Obviously, it is not possible to run through all these. It would suffice to say that we have chemical classes like oxazolidinones, nitroimidazoles, benzthiazinones, diaryl quinolones, riminophenazines, and so on. So this is the absolutely latest document from the global TB drug pipeline, updated the day before yesterday. Among the various drugs which are listed here, we have drugs in phase 1, phase 2, and phase 3, but the regulatory market approvals are available for these, the bedaquiline, delamanid, and the pretomanid. Now, if we look at what these drugs are, the hands-on drugs, because the quorum in this meeting are not hardcore TB researchers. These are people who would be handling TB. So it is better and more logical to talk to them about the drugs which we are actually using that are available to us to treat TB. The bedaquiline is a diaryl quinolone derivative, and 2 nitroimidazoles, the delamanid and the pretomanid, are the ones that are currently available to us. 2012, in late 2012, bedaquiline was approved for the treatment of MDR-TB in the United States FDA. Later on, there was a Supreme Court case on humanitarian grounds to permit the use of this drug, but the program took up the challenge and had done fast tracking for use of this drug under emergency indication under controlled conditions so that it is not misused. It's a strong bactericidal drug and has sterilizing activities against Mycobacterium tuberculosis. It has an extended half-life up to almost 5.5 months post-stoppage due to the high volume distribution, and has shown significant benefits in improving the time to culture and conversion in MDR-TB patients. It specifically targets the mycobacterial ATP synthase, an enzyme which supplies energy to Mycobacterium tuberculosis. And delamanid is the first approved drug in the class of nitro-dihydroimidazooxazoles. It is a bactericidal drug with a 36 hours half-life. It acts by 2 different mechanisms: blocking the synthesis of mycolic acids, and it poisons the bacilli with nitric oxide. As per the World Health Organization recommendations, the risk-benefit considerations for the use of bedaquiline in patients aged 6 to 17 years and delamanid in patients aged 3 to 5 years, the young age group, is also similar to what you have in adults. Retomanid is a bicyclic subsidiary of nitroimidazopyron. It has a potent activity. It is a prodrug that is converted to an active form by the nitroreductase enzyme, which hinders the amalgamation of the cell wall lipids and proteins. It inhibits the Mycobacterium tuberculosis in two ways: as an intracellular ATP exhaustion by functioning as a nitric oxide donor, and by preventing the synthesis of mycolic acid, which is an essential component of the bacterial cell wall. So how do we design regimens using the newer drugs, the repurposed drugs, the re-engineered drugs, and the available other second-line drugs? In the olden days, we had regimens based on whether it was a new patient or a previously treated patient, depending upon disease severity and the category of treatment and so on. Today, we have a wider access to technology, newer diagnostics, and newer methods of drug susceptibility testing, as well as drug resistance testing. And so this algorithm, I'm not going to read out and explain to you, but needless to say, this algorithm will give you an idea regarding how well the regimen constitution, regimen designation has been planned in the NTEP under the programmatic management of drug-resistant TB. The guidelines came out in 2021, not too long ago. So you have regimens for drug-sensitive TB, you have regimens for isoniazid monopoly drug-resistant TB, and you have regimens for the MDR or surrogate of rifampicin resistance TB, and we have longer regimens for XDR and MDR TB. So what is expected to come up? We are having a good insight into the newer drug delivery systems, like your self-nano emulsifying drug delivery systems, lipopolysaccharide polyalkylate complex systems, the haloicite nanotubes, nano cages, nano composites, nanopolymers, nanospheres, niosomes and vesicles, and so on. These are being still studied and are in the process of getting converted from the bench to the bedside. The bench work is promising. The bedside work is expected to happen in the near future. So what is the situation for the treatment of TB today? We have standardized regimens for drug-sensitive and drug-resistant TB. We have the drug susceptibility testing based regimens. We have regimens for treating latent TB infection too. And we have newer regimens in the pipeline. There is a 4-month regimen which is expected to be available soon as a part of the program. The studies are going on in certain sites due to constraints of time and the fact that it is not yet program policy. I have not given the exact details of these, and I would like to conclude here that after the hype which was generated by the anti-TB drugs becoming available and the hope it generated, to the depression it created with the emergence of drug-resistant TB, and gradually our realization with smart thinking to inculcate newer drugs to treat TB, and there is a real-time hope for reducing the treatment duration both for drug-sensitive and drug-resistant TB, and there is a push now for the all-oral treatment for drug-resistant TB. I conclude here on a very fast-changing canvas, and I request you to keep track with the program. It is futile and foolish to treat drug-resistant TB with newer drugs on an individual basis. The Government of India and the National TB Elimination Program have done very well to provide all this at no cost, not low cost, at no cost to the patient, with active involvement of all the medical colleges across the country. I conclude my presentation. I think I have stuck to my the time given to me, which is approximately 20 minutes. And over to Professor Ravi.